Good evening, everybody. Welcome to this session of 46th Comprehensive Course on Echocardiography online. We have with us Dr. Sunil Bora from Fortis Hospital, Richmond Road, Bangalore today to discuss LV systolic function. He is the Chief of Non-Invasive Cardiology at this Fortis Hospital and a very apt person to talk about on this particular function of LV, that's to systolic. Sunil has been very instrumental in conducting one of the annual conferences of CSI in Bangalore. And now he was very active when the last conference was held at Hyderabad as a coordinator or a main person after Chairman Scientific Committee, Dr. Satish Govind. Without wasting much time, I'll request everybody to please mute their mics so that disturbance does not happen. Dr. Subhash especially. And then I'll request Dr. Sunil, please start your presentation on LV systolic function. It's all yours, Sunil.
Yeah, thank you, sir. So good evening, everyone. Today we will be speaking about LV systolic function. My talk is based on this article, the guideline document from the Journal of American Society of Echocardiography. It is the guidelines on the cardiac chamber quantification. So I would recommend all of you go through this document. So very well written and good guidelines on all the chamber quantification, but then we will restrict ourselves to the LV function assessment. So we all know the quantification of cardiac chamber size and function is the cornerstone of cardiac imaging. And echocardiography is the most commonly used non-invasive modality because of its unique ability to provide real-time images of the beating heart and its availability and portability. So the left ventricle, the most commonly used parameters to describe the LV cavity size is the linear internal dimensions and the volumes. And mind you, the measurements are commonly reported for end diastole and end systole, which are then used to derive the parameters of global LV function. And to allow comparison among individuals with different body sizes, the cardiac chamber should always be reported indexed to the body surface area. So how do we do that? But before that, I would like to highlight on this important aspect. There is a cardiac cycle, which is very, very important for us to understand because we need to know which is end systole and which is end diastole. So I'm sure all of us are using ECG gated echo images, but then suppose you don't have an ECG and then you want to know which is end systole and which is end diastole, it becomes very, very important to understand which is the systolic phase of the cardiac cycle and which is the diastolic phase. So going by this cardiac cycle, here, this is the graph of the LV graph, wherein you can see this point. Before that, you will have to concentrate on the ECG, the P waves, the PR interval, the QRS complex, the T wave inversion, the T wave. So you need to be aware of this. So I'm sure all of us know that at the peak of the R wave is the mitral valve closure, which happens. And then there is this gray band, which you see is the isovolemic contraction time. So here the mitral valve closes and the aortic valve is still closed. And there is an increase in the pressure, the contraction, the isovolemic contraction, which happens. And once the pressure in the LV is more than the aortic pressure, the aortic valve opens here and there is an ejection which happens. And once the aortic pressure, the LV pressure drops below the aortic pressure, then the aortic valve closes. And there is an isovolemic relaxation time, and then the mitral valve opens again. So you need to be very, very apt about this cardiac cycle. So starting from this mitral valve closing to the mitral valve opening is the systolic phase, and then comes the diastolic phase. And then you need, if you have an ECG, you can always correlate with that. Same thing here, the pressure volume loop, you should know the pressure volume loop. It starts with the mitral valve closure, the aortic valve opens, there is ejection time, the aortic valve closes, and then the mitral valve opens. So I'm sure all of you will be able to go through this and then know the cardiac cycle and the pressure volume loop. So the assessment of the LV size, we go by the internal linear dimension. So what does the internal linear dimension mean? So it is the linear internal measurement of the LV, which should be acquired in the parasternal long axis view, which is carefully obtained perpendicular to the LV long axis. So this is very, very important. So you need to obtain the long axis, which is and we need to take the linear dimensions which are perpendicular to the LV long axis, and it should usually always be measured at the level of the mitral valve leaflet tips. I'll show you here how to do that. So we have a 2D image of parasternal long axis view, and you take a cut perpendicular to the long axis of the LV, and you get this M mode. So once you get this M mode, then you have to measure from the interface between the myocardium and the blood pool here and in the septal wall. And similarly, you have to place your caliper here at the junction of the blood pool and the posterior wall of the LV. So this will be the left ventricular internal dimension. Again, this is at end diastole, and then we have to take at the end systole. So how do you make out this? So you have this ECG. So very clearly at the peak of the R wave is your end diastole, and you take a measurement here. And at the end of the T wave is your end systole, and you take a measurement here. Suppose you don't have an ECG. Again, if you have taken a very clear cut at the tip of the mitral valve leaflets, you should be able to see the mitral valve opening. That is the anterior mitral leaflet, and this is the posterior mitral leaflet, and the closure of the leaflets. So it's very, very important. So when the mitral valve closes is the end of the diastole. So you take a measurement at this level, and just before the mitral valve opens again is the end systole. So you take a measurement of the systolic, the end systolic dimensions at this level. So what are the advantages of this technique? So the main advantage is it is reproducible. There is high temporal resolution because of the high frame rate of the M mode. And there is a wealth of published data which is there. And then there's a lot of correlation between various parameters. But then here the limitation is the beam orientation frequently becomes off axis if your alignment is not correct, if you have not taken the parasternal long axis correctly. Then you can cut tangentially. If you cut this tangentially, then it becomes the measurements are skewed. And mind you, this is a very only single dimension, and it is representative only of in a normally shaped ventricle. Suppose your apical segments are not contracting well, or the LV is not bullet shaped. If it is globular, then this doesn't hold good. And mind you, now this has not been recommended to calculate the ejection fraction and all those things, but then we still use it because we get good temporal resolution and we can give accurate measurements. And especially when we are following up a same patient over the years, it is better to have these dimension. The second technique is the 2D guided linear dimensions. Here it facilitates orientation perpendicular to the ventricular long axis. Suppose now you place a M mode line here, which is come here, then you can see here it is cutting tangentially to, and it will the measurements will be skewed. So here, in case we are not getting a perpendicular orientation of the M mode to the LV long axis, then we can take this two-dimensional derived measurement. So here it is very simple. So you still you freeze the frame in the end diastolic phase, and then you take the measurements of the interventricular septum, the left ventricular internal dimension in diastole, and then the posterior wall in diastole. Similarly, you scroll and then you see when the mitral valve opens again, and just go one frame back, and then you do the end systolic measurements. So again, here the limitation is the lower frame rates than the M mode. So sometimes it is not very clear where the image is not very clear, and then you can have some difficulty in measuring, and then the dimensions may not be correct. Again, it is representative only in normally shaped ventricles. So coming to the assessment of the LV size by volumes, the volume measurements are usually based on the tracings of the blood tissue interface in the apical four-chamber and the two-chamber views. And here, how do we do is, I'll show you in the next slide first. So the technique is, it's called as the biplane disc summation method or the Simpson method. So here what we do is we have a four-chamber view and then the two-chamber view. So here it is important that you concentrate on the LV, you adjust your image so that you concentrate on the LV. We are interested in the LV here, so you need to reduce your depth, adjust the focus, adjust the sector width so that you get a good frame rate and you trace the endocardial border. So here it is important how to trace the endocardial border. So what we do is we, in the moving scenic clip, we freeze the frame at the end diastole. So how do you make the end diastole? Again, you have to take the help of the ECG. And if ECG is not there, again, you scroll and see when the mitral valve opens and closes. And then depending on that, you need to take. And the other important tip here would be when you're scrolling it, you see which is the largest size of the LV. So whichever is the largest size of the LV in the while you're scrolling, that will be the end diastolic volume. And obviously you need to take the help of the mitral valve closure. Similarly, the end systole will be the smallest size of the LV, and you look at the mitral valve when it opens again, and then go one frame back, and then you freeze this frame. So how to do the tracing is you have to start from the medial mitral annulus. You trace this endocardial border, and here you have to be important. So you should not trace the papillary muscles or the trabeculations. You have to cut off that all those things. So here we can see a lot of trabeculation. So here very clearly they have pushed the trabeculations into the cavity, and then they've taken the actual tracing. And similarly here you can see the papillary muscle. So you should not trace it like this. You should not come like this. You should cut off the papillary muscle and you take a linear tracing. And then once you reach the lateral mitral annulus, then there is a closure line which happens. So it closes the curve, the loop gets closed, and then you have to select the highest or the longest LV axis. Similarly, you do it in the end systolic frame and then go to the two-chamber view and do it end diastole and end systole. So in this way, you get good measurement of the LV volumes. So the advantage of this method is it corrects for the shape distortions. And unlike the M mode wherein we are taking only the basal segment consideration. Suppose there is a wall motion abnormality and there is LV aneurysm or something. It corrects for shape distortions, and there is no or less geometric assumptions compared with the linear dimensions. The limitations here are the apex frequently is foreshortened if you're not taken the true LV apical 4-chamber and 2-chamber view. It can skew our measurements. And there could be endocardial dropouts, especially in the 2-chamber view. You can't, sometimes you'll not be able to see the anterior wall correctly, and you may have endocardial dropouts, and you may not be able to correctly trace the border. And it is blind to shape distortions not visualized in these views. Suppose in other views, there is some distortion in the LV shape, then you will be skewed, taking a skewed dimensions. Another method of checking the LV is the area length method. This we don't use it very commonly, but it can be used. Suppose your images are not good, and then your endocardial border dropouts are there. Then you can do this method wherein we trace the circumferential, the area basically in the parasternal short axis at the mitral valve level. And then we take the LV dimension, and then there is a calculation which happens, and then we can calculate this. But then this is of not of great help because there is not much of published data, and it's again dependent on geometrical assumptions. So how do we improve if suppose there is endocardial dropout and all those things? So there is a technique wherein we can use this contrast. It's called as LV contrast agents. We can use this to enhance the endocardial border, and it helps for us to properly trace the endocardial border and calculate the volumes correctly. So here I would like to bring to your notice. So again, you are seeing here, this is the LV contrast study which we have done. Here you can see the LV, the contrast which we have the concerned person, can he just mute himself?
I think they have to mute, otherwise I'll shut them out completely. There's
Dr.
certain people
Hoja,
are not listening at all.
Okay. So here I would like to bring to your notice. So in this view, if you are saying this, purposefully I put this image. Here you can see what does foreshortening mean. I just wanted to bring to your...
Just hold on for a second.
Yeah.
Hold on for a second.
Dr. Hoja, I think. Hoja is coming. Okay, so here, that's what I was telling about the foreshortening. So this image I put purposefully here, so to show you what is foreshortening. So here you can see the apex is contracting. So this is not actually the true LV apex. So it is foreshortened view, wherein you can see the apex is contracting. As against this, you can see this is a true LV apex, which is there. So you need to be cautious about this whenever you're doing the volume. So you should not see this type of image or a clip wherein the apex is looking like as it is contracting. So this is a foreshortened view. So here we use the LV contrast to opacify the LV, and we trace the endocardial border, and in again the same method wherein we use the 4-chamber view, 2-chamber view, and then we calculate the end diastolic volume and the end systolic volume. So this is very, very important because it is helpful in patients with suboptimal acoustic window. It provides volumes that are closer to those measured with cardiac MRI. The limitation is same as non-contrast 2D techniques and acoustic shadowing. So there could be a lot of shadowing in the basal segments if the contrast is not given properly or slowly. Then it can again cause problems in endocardial border definition. So another method is the 3D volumes. This I'm sure not many of us are using, but then if your machine is having the capability of 3D echo, this is definitely indicated. Again, this is same as the 2D method, but additionally we're using the apical long axis view or the 3-chamber view, wherein all the three views are used to create a 3D cast, and we can calculate the volumes. Advantages is there is no geometrical assumptions here. It is unaffected by foreshortening. It is more accurate and reproducible compared to the other imaging modalities. Limitations, again, there's temporal resolution is less in 3D imaging. There's less published data, but in off late there are a lot of published data. And again, it is image quality dependent, and availability is definitely an issue. So the normal reference values for TD, the 2D echo derived parameters is in male and female, there are different dimensions. So there will be internal dimension in end diastolic will be 50 is the mean cutoff for men, and 45 millimeters is cutoff for the female. And similarly, the end diastolic volume, which we are more interested in the end diastolic dimension, so which you need to concentrate on, and the end diastolic volume, that is 106 mean 106 ml mean in male and 76 ml mean in female. And based on that, we can calculate the EF. Again, 62% is the mean in a normal reference range. So coming to how to evaluate the global systolic function. So here the most important thing is, again, we are looking at the global function. So there are various methods to know this. One of them is the fractional shortening. So here by the M mode imaging or from the linear measurements, which I showed in the previous slides, we can use this and we can calculate the global LV function parameters from this linear measurements. So once we do that, I'll tell you more about the global function later when I'm dealing with the regional function, so that it becomes easy. There are common things. So how do you calculate ejection fraction is by the, one is we can get by the internal dimension, that is by M mode or the 2D derived linear measurements, wherein we can use the calculation of fractional shortening into 0.96, we get the EF. But then the most accurate method is by the Simpson method. You calculate the EF by calculating the EDV and the ESV. That is the end diastolic volume and the end systolic volume. And by using this formula, there is end diastolic volume minus the end systolic volume divided by the end diastolic volume will give the ejection fraction. And the Simpson method is the recommended method to do this. So a recommendation is, again, the LV systolic function should routinely be assessed using both 2D or 3D, and calculate the EF from the volumes rather than the linear measurements. And the normal ranges are always given. Any EF less than 52% for men and less than 54% for women is considered abnormal. So coming to the regional function evaluation, I'm sure all of us know that detection of regional wall motion abnormality is integral to the evaluation of the LV function. And analysis of the regional wall motion abnormality is characterized by considerable inter-observer variability, even using high-quality imaging modalities. So there's a lot of inter-observer variability. So we need to keep this in mind whenever we are evaluating regional wall motion abnormality. And as a novice, there is a learning curve, and then you need to go through that. So what do I mean by regional wall motion abnormality? So here what we are looking at is endocardial motion and systolic thickening. So here you can see in the short axis. So you're seeing this endocardial motion, and you are also seeing that the LV there is some systolic thickening which is happening in all these views wherever you're seeing. So there is endocardial motion and also the systolic thickening. So whenever we are assessing the regional wall motion abnormality, we are looking at both of them per se. So we need to look at how the endocardium is moving towards the center and also how much the myocardium is thickening. So this is what we mean by looking at wall motion abnormalities. So the regional motion is influenced by the regional flow, that is the regional blood flow to that particular segment, which again is responsible for the regional thickening. Also, there is influence by the tethering or the hyperkinetic effect. So what do I mean by tethering effect is, suppose there is a kinetic segment or a hypokinetic segment, and then what will happen is, because of the normal segment, there is a influence on this theta segment. And here you can see I put here. So this the left side image is a normal myocardium which is contracting well. So here you can see there is some hypokinetic segments, but then because of the tethering effect, they look as though they are contracting, which is actually not. So if there is a 20% involvement, suppose this segment is involved, but then because of the tethering effect, we tend to overestimate the ejection fraction. So we need to be aware of this tethering effect or also the hyperkinetic effect. Suppose the patient is tachycardic. So again, it is very, very difficult for a novice to know or detect the wall motion abnormality. Again, the cardiac translation and rotation during systole affects the regional motion, and then the cardiac motion during respiration also affects the regional motion. And loading condition, be it the preload or afterload, it again affects or influences the regional motion. So what is the most common cause of regional wall motion abnormality? I'm sure all of us know this. So it is a coronary artery disease. So you should know the coronary anatomy to know how to evaluate the regional wall motion abnormalities. So I'm sure all of us know this basics, but still I'll go through it. So we have the left main artery, which divides into the left anterior descending artery and the left circumflex artery, and then the right coronary artery, which again continues as the posterior descending artery. So you need to know the anatomy. So again, the ischemic cascade also needs to be known. So whenever coronary artery gets obstructed, there is a sequence of events which happens, and this is the ischemic cascade. And by the time the patient develops angina, there's a lot of other variations which happens inside the myocardium, starting with the perfusion abnormality, the diastolic dysfunction or relaxation abnormalities, the abnormal strain, and then visible wall motion abnormality and ECG changes. So here you can see that before the ECG changes occur, there is a visible wall motion abnormality which we can pick up earlier as echocardiographer. So you always echo has an upper edge to diagnose coronary artery disease, especially when we are doing, say, for example, stress echo. So it is very, very important for us to know this one. So before I go to the wall motion abnormality evaluation, we should be aware of the LV segmentation, which is very, very important, and the basis of our description of the wall motion abnormalities. So here you can see in the 4-chamber view, we have the septum, that is the inferoseptum, and the lateral wall, which is again divided into 3 parts. So the basal anterolateral wall, the mid anterolateral wall, the apical lateral wall. Similarly, the basal inferoseptum, mid inferoseptum, and the apical segment, and we have an apical cap. In 2-chamber, we have the inferior wall and then the anterior wall, which is again divided into basal, mid, and the anterior apical. In the long axis or the 3-chamber view, we have the basal inferolateral, the mid inferolateral, which is and then the apical lateral wall, and the basal anteroseptum, mid anteroseptum, and the apical anterior. So here you should be aware that the apical segments are 4 in number, and we can see the same segment, the apical anterior segment, in the two-chamber view and then the long axis view. And similarly, in the short axis, we have the basal segments, mid segments, and the apical segment, which are again divided into 6 segments in the base and the mid as the septum. So the septum is in between the RV and the LV. So and this is divided into 2 parts, the anterior septum and the inferior septum. And then we have the anterior wall, the inferior wall, and then the lateral wall is divided into anterolateral and then the inferolateral. Similarly with the mid segments. And in the apex, we have only the anterior, inferior, septal, and the lateral segments. So I'm sure all of you should spend some time in labeling this segments, which is the basis for our understanding of the wall motion abnormality. And this is a bullseye plot. Very clearly, you can see the 17 segment model. So these are the basal segments 1 to 6, and they can be labeled as the anterior wall, the anterior septum, inferior septum, the inferior wall, then the lateral, the infralateral, and then the anterolateral. Similarly, the mid segments, and then the apical segments, and then the 17th is the apical cap. So having said this, we should always again had this about the arterial distribution. So we have the left anterior descending artery, the right coronary artery, and then the LCX. So in the 4-chamber view, you can see here there is an overlap of supply from the LAD and the LCX. So the lateral wall can be supplied by both or majority by one of the arteries, whereas the apical septum and the LV apex is exclusively supplied by the left anterior descending artery. And the basal inferior septum is supplied by the RCA, and then there's a watershed zone for the mid segment. In the 2-chamber view, you can see the anterior wall, the whole of the anterior wall is supplied by the LAD, and the apical inferior segment is supplied by the LAD, whereas the basal and the mid inferior segments are supplied by the right coronary artery. In the 3-chamber view, again, the anterior septum and then the apical anterior wall and the apical inferior wall is supplied by the LAD, whereas the lateral wall is supplied by either the RCA or the LCX. And similarly, the basal segments and then the apical segments in the short axis. So having said that, how do we assess the wall motion, regional wall motion abnormality? So my take on this is you should never explain or describe your wall motion abnormality based on 1 or 2 echocardiographic images. So you have to look at as many views as much as possible, and then only you need to give your opinion on the wall motion abnormality. So you have to start from the standard views, that is the parasternal long axis, the parasternal short axis, the apical 4-chamber, the 2-chamber, the 3-chamber, and also go to off-axis view. So this is one of the off-axis view which I have put. This is a modified parasternal long axis view wherein we can see the apical segments also. So you should make it try and make an attempt to see as much as possible, because sometimes if you don't see in the short axis, you can see in the other views, and then if you're not seeing in the other views, you can clearly make out in the short axis view. So you should utilize as many views as possible to describe the wall motion abnormality. So what are the methods of analyzing wall motion? So the ventricular segments are analyzed based on the following methods. The first one is the qualitative method, wherein we are looking at the wall movement and the wall thickening. And this is indirectly also called as the eyeball assessment. So here, I'm sure all of us are doing this, but then I would not recommend this to be the sole method of assessment and describing the segments, especially for a person who is starting to do echo or who is not very experienced on this one. So the eyeball assessment improves by experience. So here we look at the normal motion or hypokinetic, akinetic, or dyskinetic. I'll describe this in my next few slides. And also we look at the presence of scar or aneurysm. So this is basically only a qualitative assessment. So we don't have, so the problem with the qualitative assessment or this eyeball assessment is there's a lot of inter-observer variability. Suppose I am telling it is normal, some other person may tell it is hypokinetic, like that. So there's a lot of inter-observer variability. So to improve on this, we have something called as semi-quantitative assessment, wherein we score the wall motion by giving a score to each of these segments, which are either normal, hypokinetic, akinetic, or dyskinetic. Again, I'll explain to this in my next few slides. The most important, the most advanced one is the quantitative. So here we are giving some value or some objective evidence that, okay, this is hypokinetic or this is a abnormal segment. So here we have various methods. The one is called as fractional shortening or the radial shortening, then the fractional cavity area change, and then the Doppler tissue based methods. So before I go into the details of each one of them, so we should know this nomenclature on grading of the wall motion abnormalities. So if the wall thickening, we look at the LV wall thickening in systole. So if the wall thickening is more than 35 to 40%, then that segment is called as normokinesia. That segment is having a normokinesia, and we give a score of 1. So if the wall thickening is between 10 to 30%, then that segment is hypokinetic and a score of 2 is given to that segment. And if the wall thickening is less than 10% or there is no inward movement which we see, that is the systolic thickening, then that segment is labeled as akinetic and a score of 3 is usually given. And in systole, if the wall segment is moving outward, that is away from the center line, then that segment is a dyskinetic segment and a score of 4 is given. And if it is bulging outward during diastole also, during systole and diastole, then that segment is aneurysm and we give a score of 5. So coming to the eyeball assessment. So here I put 3 videos. We don't have interactive session here, so I would take this as per se. So here you can see this clip is a normal segment wherein all the segments are contracting, and then there is endocardial motion, and then there's systolic thickening happening in all the segments. As compared to this, I'm sure you should be able to make out there is a hypokinetic or akinetic segment. Here you can see in this segments there is akinesia. So these segments are not contracting. Basically, they are less than 10% of contraction. So these segments are severely hypokinetic or akinesia, we can say. As compared to this, again, if I show this to a person who doesn't do echo regularly, he would say it is normal. But then if you see closely, there is a segment which is thinned out here and it is not contracting. So this is, again, I wanted to show this an example for the tethering effect. So this segment seems to be contracting, but it is not actually not contracting, and it is getting pulled by the other normal segment. So this is called as a tethering effect, and this is a akinetic segment. So in eyeball assessment, there is a lot of inter-observer variability. So this is not recommended as a means of describing the wall motion abnormality. Again, here we can see the other segment, like for example, the presence of a scar. So this you can see as compared to the previous image, you can see this segment is thinned out and it is very bright and it is not contracting at all. So this is a scarred segment and it is akinetic or probably dyskinetic. It is moving away from the midline. And this is a clip wherein you can see the aneurysm and along with the LV apical clot. So this segment is aneurysmal here and it is going away from the other segments. When these segments are contracting, this segment is moving away. So this is called as the aneurysm. Similarly, here you can see this segment. Again, it is the whole of this lateral wall is severely hypokinetic. So going one step forward is called as the wall motion score index. So here the same segmental description we use, but then we give a score. So how do we give a score? Is we sum of all the wall motion scores for each segment. Suppose now this segment is there, we give one like we give scoring to all the segments here. Suppose this is a normal segment, we give a score of 1, and this is a akinetic or dyskinetic segment, we give a score of 3 or 4. So we add one each of them, and suppose we have given a score to all the 17 segments, then we divide by 17 and we give a score index. So if normally it should be 1. So if it is more than 1.3,
आपकी चलती है बात करा के मंगा तो बोलिए आप नहीं अंदर ओपन नहीं है नहीं भैया सब आज तो बाहर हमको तो ना हमको बाहर हो रहे आप तो घंटे से वेट कर रहे हैं हाँ
Okay, so we give score to each of the segment and divide the number of segments which we have scored, and we give a objective value. So it is helpful in, especially in coronary artery disease, to find out which segment, which artery is involved more. So this is one way of objectively assessing. So another method of quantitative assessment is something called as fractional shortening. So this is nothing but what we do in M mode assessment, where when we are seeing the fractional shortening is, it is calculated by the percentage change in the LV diameter during systole by using this formula. So what we do is we calculate the LV end diastolic diameter and minus it from the LV end systolic diameter. So we measure this LV end diastolic diameter, and then we again measure this LV end systolic diameter, and then we divide by the LV end diastolic diameter. If it is more than 28%, it is considered to be normal. So hypothetically, we can take any of these axes, whether it is anterior-posterior axis or the anterior-inferior axis or the septolateral axis, anything we can take. But then again, this is not useful in abnormal LV. This one, it is more useful in a normal LV to give the this one. So the other method is called as the fractional cavity area change. So this is a little more robust than the previous method, wherein here in the short axis, we are tracing the endocardial border. So what we do is at the parasternal short axis view in the papillary muscle, at the papillary muscle level, we trace the endocardial border. Again, here you have to make sure that you don't include the papillary muscle or the trabeculation. So you need to exclude them into the cavity, and then you trace it in the end diastole and in the end systole. And by using this formula, LV end diastolic area minus the LV end systolic area divided by the LV end diastolic area, we get the fractional area change. So if any value more than 35% is considered to be normal. So again, the fractional area change can be used to estimate the ejection fraction. And here you can see in this example, this is a normal wherein the fractional area change is 60%, and then the ejection fraction is 75%. Similarly, here, all the segments are contracting less, and the EF here is 54% as compared to this, wherein the EF becomes 30%. So this is very, very useful as eyeball assessment also, but then this is not recommended in patients who have regional abnormalities. So it is more useful in global assessment of the global LV function. So another method is the wall velocity or the myocardial displacement. Here we look at the myocardial velocity. So here is nothing but this is called as a tissue color tissue Doppler imaging, wherein we look at the lower velocities of the myocardium and we calculate the LV function. But here again, this is not useful because it is only one dimension which we are looking at. Like we are looking at only the mitral annular movement. So this is again useful only in normal looking LV, wherein we look at the global function and we measure the S prime wave, that is the annular motion towards the probe, and we calculate. So any value above 10 is considered normal. So this is equal to again MAPC. So the mitral annular, the tissue or the M mode method, wherein we look at the mitral annular displacement. Similarly, by tissue Doppler, we calculate the velocity. Again, there are based on this method only, we have advanced method called as the strain or the strain rate imaging. So here, so what do you mean by strain? The strain is nothing but it measures the tissue deformation, that is the change in the dimension or length, which is normalized to the initial length of the region of interest. So what do I mean by that? So here you can see the myocardium. This is a septal wall wherein we are looking at one segment. So we are looking at only at the mid infroseptum, wherein we are seeing that in the diastole, it is about 10 centimeters here. And in the systole, it becomes 8 centimeters. So it changes, it deforms. That is, the myocardium deforms from 10 centimeter to 8 centimeters. So we give a value of minus 20%. Similarly, suppose it was elongating. So if it was like akinetic or dyskinetic segment, then it becomes a plus sign. And again, in the radial thing, we give it as plus 20, but I don't want to confuse you. And then if there is no change from post 10, it is remaining 10, then that segment is probably akinetic or very severely hypokinetic. So strain rate is nothing but when we look at how fast or against the time, how much the myocardium deforms or changes its length, then that is called as the strain rate. So to understand strain imaging, we should know something about the myocardial mechanics, which is very, very important. So I'll quickly go through the myocardial mechanics. So what do we know by that? So we all know by anatomy that the fiber direction changes from the right helix to the left helix, from the subendocardium to the subepicardium, and the directions of the circumferential or the mid-wall fibers are usually circumferential. So here you can see, and this is basically used for understanding the myocardial mechanics. So longitudinal mechanics, so when the longitudinal fibers contract, there is a change in the shape of the LV. So it reduces in its length. So from diastole to systole, there is a movement of the LV from the base to the apex. So mind you, the apex is fixed. So only the base from the basal segment, it moves towards the apex, and there is a change in the longitudinal dimension of the LV, and that we measure, and we give we calculate the longitudinal strain. Similarly, circumferential strain is nothing but when the LV contracts, there is a change in the shape or the movement of the myocardium, basically the middle fibers, wherein there's change from the circumference, it changes. So from 4 centimeters become 3 centimeters. So this is what we calculate as circumferential strain. And in radial strain, where we see the change in the thickening of the LV. So this is basically the function of the circumferential fibers or the middle fibers. So here, this is nothing but what we see routinely in our M-mode echo, wherein we are seeing the radial thickening. And I'm sure all of us know that the myocardium moves clockwise and anti-clockwise in the basal and the apical segments. And this, as a result, there is a twist, and it's like the squeezing effect, wherein that contributes to the ejection fraction of the LV. So as a net effect, because of all these mechanics, whether it's a longitudinal, the circumferential, the radial, or the twist mechanics, the net effect is the LV contracts, and then there is a ejection of the blood which happens. So coming to understanding spectral tracking, so here what the echo machine does is it identifies each of these myocardial speckles, and it tracks each of them and over the time, and then sees how much it is moved. So this is basically the tissue Doppler method, wherein you are using to detect the segmental analysis of the each segment. So here we are looking at all these segments, and then in the time frame where we are seeing how much it is moving from its initial to the final in the successive frames, we seeing the movement of these speckles. So 2D speckle image acquisition, what we do is the goal here is to go from the subjective expert evaluation, that is from the eyeballing to the quantitative information, to quickly get a quantitative information so that we can reduce the inter-observer variability of assessing the wall motion abnormalities. And it's done very quickly. So it's very easy to do. Suppose we have a machine which is capable of doing strain imaging. I would recommend all of you go and check out on your machine and then try to do this. So how do we convert this into a daily practical clinical application? So here, the first thing is we need to have a good machine setup. So we should have high frame rates of at least 40 to 60 or 40 to 80 frames per second. The images should be of good frame rate. How to do this is by optimizing the image, by adjusting the focus position, reducing the sector depth and concentrating only on the LV, and reducing the sector width so that we can concentrate only on the LV, but do not reduce it so much that the segments get cut off. And then always avoid artifacts. The imaging should be very neat and crisp, and then there should not be any respiratory artifacts or movement artifacts. And avoid foreshortening, and as I told previously, and then all the images should be ECG gated. So how do we do that? We just require 4 images: the apical 3-chamber view, the 2-chamber view, the 4-chamber view, and then the short axis view. And then once you've acquired this, you can do it offline or online. and you just place the points. The machine will guide you. It is very easy. You need to just place the points 1, 2, and 3. That is the basal, the annular points and the apical points, and then it will trace the endocardial border and it will give these values. So we can calculate the global strain, longitudinal strain, and also the radial strain by these methods. So here it will also give the regional strain. So we can know what is happening to each of the strain, whether there is hypokinetic segment or ekinetic segment, all those things. And it will give you good curves. So here you can see all the curves are concurrent, and all of them are contracting, and then they're reaching the peak systolic contraction. And this bullseye plot, which is looking very neat and red. So that means all the segments are contracting simultaneously and concurrently. So again, this is the same thing, wherein you can see this, all the segments are in red. So it is more than 18%, and then the average is minus 20%, so which is normal. So these are a few of the abnormal examples. Herein you can see is the segments are not contracting, few of the segments, and then you can have some objective evidence, and the global strain, wherein it shows that the LV function is reduced. And if you look into very closely, we can see that some segments are actually dyskinetic here. The importance of the strain imaging is it gives an objective evidence so that the inter-observer variability is less. So I'll not go into details because I don't think it is very. This is another example wherein we can see that the global strain is reduced and the individual segmental strain also is reduced. Here you can see in the posterior segment, the infero-posterior wall is hypokinetic or dyskinetic. So the recommendations of for evaluation of LV global systolic function is to use speckle tracking derived GLS, because it is reproducible and feasible, and it offers incremental prognostic data over the LVEF in a variety of cardiac conditions. And GLS in the range of minus 20% can be expected in a healthy person, and a lower value is most likely to be abnormal, and we need to look into the details of its abnormality. The limitations of regional wall motion assessment is the regional wall motion assessment is influenced heavily by the image quality, the endocardial border definition, the angulation of the transducer during acquisition of short axis view is very, very important. So here I want to bring to your notice. So whenever you're acquiring the short axis, suppose the basal, the mid, and the apical short axis, you should not just angulate the probe, but then you should slide the probe so that you get perpendicular views. So you should always use this technique wherein you can slide your probe from, say, from the second intercostal space, you need to go to the third intercostal space to take the apical short axis views. And also the translation and rotational movements of the heart during cardiac cycle needs to be kept in mind. And then the valsalva maneuver, suppose the patient is breathing heavily and then it's holding his breath, then that can also affect. So you need to consider all these things and rectify them. Having said all those things, we should also be aware of the non-ischemic regional wall motion abnormality, because this you will often see this, and then you need to be aware of these, and so that you analyze the wall motion abnormality properly. So the most important is the conduction system abnormalities, presence of LBBB, ventricular pacing, or premature ventricular contractions, or WPW syndrome, and also the septal abnormal septal motions in cases where there is right ventricular volume overload or pressure overload, and in pericardial constriction. And then post cardiac surgery patients, you can have some septal bounce movements, and then the other rare causes. So the limitations of wall motion abnormality assessment is in up to 20% of resting studies, the endocardial border definition is suboptimal. So what does this endocardial border being suboptimal mean? So it is defined as the inability to visualize at least two myocardial segments of the LV. So if two myocardial segments are not seen, then that is it's very difficult to do the Simpson evaluation. And mind you, nowadays there's not much of fundamental imaging which we use. So almost all the machines have tissue harmonic imaging, which has significantly improved the endocardial definition. But then, however, 5 to 10% of the studies employing this tissue harmonics also can be suboptimal. And again, mind you, you should be aware of the tethering effects of the endocardial excursion and the wall thickening. And whenever you are assessing the wall motion, you should keep this in mind. And what are the various ways to improve the detection of regional wall motion abnormality? So you should know how to select your probe. So whether it's a pediatric probe or adult probe, or select the frequency, improve the image resolution by adjusting the frequency, adjusting the beam width, and improve the temporal resolution or the frame rate by adjusting the sector width and the sector depth. And always use tissue harmonic imaging, which is already there nowadays. And to optimize the 2D image, we should adjust the gain, adjust the focus position, adjust the depth. There's something called as dynamic range. You need to adjust that. But then these are all not done on routine basis. So suppose you're using a machine regularly, you can just adjust one time and then you get used to that. Always use the zoom button so that you can concentrate on the particular area of interest. Adjust the sector, but don't keep it too wide or too small, and adjust the imaging frequency based on the patient's body habitus. So if it's a very obese patient, you keep the lower frequency. If it's a very thin patient, you keep a higher frequency adjustment. And then look at the frame rate. Okay, I don't know where it is gone. Sorry. So, and then we can also use the different color maps for the grayscale imaging and improve our detection of the wall motion. So suppose you're not able to do that, then there is always this contrast echography, which comes very handy if your machine is capable, or if you have access to the contrast agent, that is LV contrast. It is very useful because we all know that echocardiography per se has limitations when there are poor acoustic windows based on which we can't define the structure, we can't look at the endocardial border properly, we can't assess the regional wall motion, and also the Doppler signal sometimes can be very difficult for us to look at, especially if you want to look at tricuspid regurgitation and want to calculate the pulmonary pressures. It is important that Doppler signal is good. And as a consequence of the suboptimal images, we often misdiagnose, we have low diagnostic confidence, there are need for additional tests which will be required, and obviously there are inter-observer variability. So to address all these things, we have contrast echo, which can be injected intravenously, and they enhance the echogenicity of the blood. The goal of the contrast echo is to improve the endocardial border definition, enhance the Doppler flow signals whenever we are not able to look at the Doppler signals. And then again, we can look at the perfusion. It has increased sensitivity. There is heightened diagnostic confidence. There is enhanced clinical utility by using this. So contrast echocardiography, basically we have agitated saline, which is used for the right side heart opacification, and the LV opacification, wherein we have these heavy gases which are having high molecular weight and low solubility, and they can the microbubbles are lesser than the RBC size of the RBC, and they can easily pass through the pulmonary circulation and come to the left side, and we can use this to opacify the LV. So the contrast agents, many studies have shown the incremental value of using contrast agents by improving the image quality, and improving the percentage of wall motions visualized, and also improving the confidence. So these are the few examples of using the contrast. Here you can see this is a routine image wherein we are not able to define the endocardial border in this lateral LV segments, and by giving the contrast, we can see the endocardial border definition clearly. And then in fact, there is a LV apical thrombus here, which was probably missed out on this image. Again, to define, suppose you're having aneurysmal segments and you're not sure whether there's a LV apical thrombus, you can always give a contrast and then rule out or confirm the diagnosis. So the recommendations for LV regional function is to use the 17 segment model and to assess the wall segment in multiple views, and use the grading scoring system and label them appropriately, and give a descriptive finding of the wall motion abnormality. Again, here a word of caution: the speckle tracking echo or the strain imaging should not be used for regional LV function assessment, because it is still not recommended because of the lack of reference values, and again suboptimal reproducibility. The last few slides on LV mass. LV mass is a very important risk factor and a strong predictor of cardiovascular events. There are several methods that effectively calculate the LV mass from the M-mode echocardiography, or by 2D or 3D echocardiography. And to measure the LV mass in an individual patient over time, especially those with cardiac disease and, say, for example, hypertensive heart disease. 2D echocardiography methods have the advantages compared with the linear dimension technique. So whenever we are following up a patient, we can use this to assess the LV mass. So how do we calculate the LV mass? By the M mode tracing or the 2D methods, we can use this Q formula. And this can be used. This usually we don't have to remember. It is all in, like it's there in the machines which is already feeded, and we just have to calculate the LV internal dimension and the posterior wall thickness, and it gives the value. And all the measurements of this for this LV mass calculation should be at the end as told. And the advantage is it is fast and widely used, is very wealth of published data, etc., etc. And there are a lot of limitations because it involves a lot of assumptions on the LV size. And this one. Again, we can usually calculate by for measuring the LV internal dimension and the posterior wall thickness, and we can use the formula to calculate. 3D, again, it can be used to calculate. I'll not go into the details of this. The recommendation is in normally shaped LV, both M mode and 2D echographic formulas can be used to calculate the LV mass. Normal value is 95 grams per meter squared in women and 115 grams in men. I'll skip this. I think I'll come to an end of this. So these are the reference values. You can look at the guideline document and you can add this. Relative wall thickness, again, this is very, very important to describe or differentiate between concentric remodeling, concentric hypertrophy, eccentric hypertrophy, or a normal geometry. Here, by using this formula, 2 times the posterior wall thickness divided by the LV internal dimension at end as told, it will tell you we can calculate the regional wall thickness. If it is more than 0.42, it is concentric LVH, and if it is less than 0.42, it is eccentric. So eccentric means both the LV is dilated and hypertrophied. Say, for example, in aortic regurgitation. So wherein we have eccentric hypertrophy, whereas in hypertension, we have concentric hypertrophy. And it also allows the identification of concentric remodeling, that is normal LV mass with increased regional wall thickness. So I think I'll end here and we can take some questions if are there.
Sir, Dr. Prasenjit here.
Yes, yeah.
While calculating ejection fraction, Simpson method will be the better than M mode, sir.
Yeah. I told in my starting slides, no, M mode is not recommended for calculating the EF. We have to use the Simpson method to calculate the EF.
But most of the actually residents and everything, those who teach us, they do the M mode only, sir.
So that is why we have